those of you that haven't met me, my name is Emma. I am a third-year medical student at Burrell College of Osteopathic Medicine in New Mexico. Today we are going to be talking about an important organ, our liver. Not just important for Friday nights, but important for a lot of functions that sometimes are underappreciated. So we're going to talk a little bit about that, and just know that really the breadth of liver pathology is pretty extensive. And so we're going to cover some things, but there are going to be some things of which we don't touch on today. So everything really won't be covered today, but I wanted to kind of give you a wide sort of presentation nonetheless. Okay, so let's see. All right, so as always, I have a book here. This one is a little more about our talk today about the liver, obviously, but this one is about a man of whom had battles with different neurological disorders. And so I do recommend this book. Oliver Sacks wrote a few neurological sort of books. And Stephanie, sorry to hear about that, about your dad. I can attest to that too. My dad had pancreatic cancer and he died when I was in high school. So I understand where you're coming from with that. Okay, so on a little more of a lighthearted note here, the liver is important for a lot of things, and I think the one to the right here is funny. But at any rate, let's get started with the pre-poll here. Let me launch this pre-poll. So as always, fill this out kind of honestly, and we'll see kind of where you stand, obviously now, and then at the end of the presentation as well. There's a few of you guys out there. Looks like we're at, okay, perfect. We're at, looks like 27 out of 28 now, so I'll stop it here and share this with you. So it looks like the majority of you guys, 67% of you say that you know a little bit. Some of you said, I know nothing, that's okay. Some of you said, I know some. So it seems like the vast majority of people kind of fall in that middle zone, I know a little bit, and that's okay. I hope by the time, we finish this presentation today, most of you will be in the I know some and I know a lot categories, maybe. Let's kind of get started here with our presentation today. So as always, we're going to kind of go through the case. We'll talk a little bit about the corresponding physical exam. We'll kind of think of some differential diagnoses together. We'll kind of conjure up an assessment and plan, and then we'll talk about the actual pathology of the disease at the end after we've kind of had that cemented case in our mind. I think that's the best way to learn by far. And you'll see that when you get to your clinical years as well, you'll kind of remember these patients that teach you these diseases. So that's kind of my role. I've seen some comments in the feedback form, which we absolutely appreciate when you give us feedback about having the pathology first. And I kind of meticulously lay it out this way because I think that having seen the case helps you really cement that in your mind. And I hope that is the case for you guys. I hope you guys are really learning a lot through these sessions because we're happy to do them. So tonight, what I want you guys to do is actively participate. You guys do a great job of that, and I love that. I think that is really what differentiates our virtual rounds from other ones out there. The other thing that you'll do is you'll fill out that SOAP note that Becca put into the chat, and then afterwards fill out the quiz, and then give us feedback, please. We appreciate that. There's in the chat, Becca just put the feedback form, the quiz, and the SOAP note link. And then we have a few resources available for you all. That link is in the chat as well. And here's kind of the snapshot of the SOAP note, what it looks like. And then for those of you of whom this is your first time joining us, first welcome. And then what we're going to do throughout this is really discuss a lot of different things going on with the patient and then kind of fill them out in this kind of SOAP note format. So subjective is going to be the things that the patient is telling us. So things in the history of present illness when you're interviewing the patient, things in the ROS, which are pertinent positives and pertinent negatives to what's going on with the patient. Objective information is stuff that, you know, we find on physical exam or results that we get, vital signs, etc. That will go in the objective part. Assessment is going to go along with our differential diagnoses and what we think the patient might have based on their case. And then the plan is going to kind of be in corresponding to those differentials. What do we want to do in order to treat this patient specifically for what we think they may have or what we know they have based on their results? All right. So let's get started here with this. So today we have a 47-year-old male with a past medical history. That's what PMH stands for, significant for hypertension. He's presenting with a 3-day history of shortness of breath. He describes shortness of breath at rest, which is exacerbated by ambulation, so walking. His spouse is present, of whom states that the patient has been more yellow than usual and a little disoriented. The patient describes intermittent episodes of nausea and vomiting, occasionally with blood, but denies any syncope, that means fainting, chest pain, or loss of consciousness. The patient is a daily drinker of alcohol and consumes approximately 1 6-pack of beers per day for as long as I can remember. History is also positive for fatigue, diffuse abdominal pain, and bloating with weakness. No previous similar episodes. The patient takes lisinopril for their hypertension, but denies any other medications. So kind of try to cement this picture in your mind of this patient, what this patient may look like, what kind of things are pertinent to the case. Okay. So questions we want to consider today. The first one of which is, what are the important differential diagnoses to consider at this point? Knowing, you know, a few things that are going on, what do we want to consider? I know this is a lecture about liver, but I want you to kind of think outside the box. What other things other than the liver, in addition to the liver, I do want you to tell me the liver ones as well, but what else can be causing this kind of complex of symptoms that we're seeing today? So we have a liver cirrhosis, good. Ruptured varices, certainly ruptured varices could be causing this, sure. Acute pancreatitis, yeah, absolutely. In pancreatitis, you do absolutely get jaundice, so good job. Something related to bilirubin, yeah, absolutely. When we see a yellow patient, we want to, you know, think bilirubin for sure. Anybody else? Think organ systems. We can think kidney, yeah, kidney can mess up a lot of things for sure. If you have a problem with the kidney, perhaps you can't, you know, clear bilirubin, you have a problem with bilirubin metabolism. Gallbladder, absolutely, yeah, good job with the gallbladder. If you have a stone, you're certainly going to have problems with bile and excretion of bilirubin as well. Something wrong with the kidney, which could lead to hypertension. That's something to consider as well, for sure. Anybody else? He has shortness of breath. What do we want to think with shortness of breath? That's his presenting complaint. We could think anemia. Yeah, you guys are relating to all my presentations in the past, which I like. What about, yeah, COPD, good. Pulmonary disease, lungs. One other thing, I'm waiting for one thing before I go on to the next question. Could be in shock. Possibly, we don't know just yet. Pancreas, yes, you're close. Yeah, we want to think about pancreatic cancer for sure, especially in somebody of whom has lost weight. left ventricular hypertrophy. So you're close. What I'm looking for is congestive heart failure. And I was looking for that. It's kind of a reach, but we want to consider that with somebody who has hypertension, fluid overloaded, could have left ventricular hypertrophy leading to congestive heart failure. So that's something we want to kind of put in our differential because we don't know whether it's a liver problem at this point, okay? So the next thing is what details are of the utmost important? What is standing out to you right now? And what about the social history is important? What did this guy tell us that we should be narrowing in on at this point? Active drinker, yep. Good, he's a regular drinker. Good job, guys. What else? Good. He had vomit, yeah. So what we call blood in the vomit, we call that hematemesis. So he does have a little bit of hematemesis that we want to take seriously, obviously. He does have jaundice that's going to be important as well. Anybody else? Bloating, good, yeah, exactly. So he does have bloating, and that's something to take seriously, especially in women and older women. We see bloating, we see early satiety. We want to think of what? If somebody knows this, I'll be very happy and very proud of you guys. Older women, postmenopausal with bloating, maybe abdominal pain. What disease process do we want to think about? Does anybody know that one? That one's ovarian cancer. I don't expect you guys to know that. I just wanted to see if anybody did know that. We want to think about that. So as we're kind of progressing with this, I want to really push you guys to think outside the box, to kind of spread out your differential diagnoses, even at the level that you guys are at, because as you guys kind of grow in your education, you're going to get good at that. And that's really going to be what's important, is to think outside the box. If you think it's one thing, great, but you have to take into consideration those other things, because when you don't, you're going to forget something, okay? Encephalopathy, is that what you were going for, Stephanie? I think that's what you were going for, which you're right. It is encephalopathy. It's a hard word. There's a lot of vowels going on there. Hypertension with vomiting and nausea could be CVA. Good. I like that you guys are thinking outside the box here. And do we believe this guy, if he says he drinks a 6-pack a day, do we believe that it's only a 6-pack? Nope. Yeah, you guys are all right. I wouldn't believe that. There's always that rule, you can like multiply it by 2 or add 5 beers, or what, you always hear different renditions of it, but the patient probably drinks more than that. Okay, so our next question we want to consider is what other questions should we ask this guy? And he has a little bit of altered mental status. He's a little bit disoriented. So what might we ask his spouse, maybe? Good. How long ago the symptoms started? Okay. Maybe how long he had jaundice. Good, good. Medications, good. What are his current medications? Good. Those are very important questions, both from Trish and Emily. Good job. How long has he been drinking for? Good. Yeah, much like cigarette smoking, we want to ask, okay, you're drinking this much per day, for how many years, for how many days, how many months? Exactly. Good. And in terms of the drinking, there's one specific thing we may want to kind of gauge for him. Do you guys know what that is in terms of his drinking habits? How is his diet? Does he exercise? Good. Yeah, those are always important things to take into consideration. Good. The thing I was trying to get at with the last question I had for you guys is, one important thing to ask is, does he withdraw from alcohol when he stops drinking? That's a very good sign that this person, could go into withdrawal seizures, could, have a problem with alcohol seriously. All right. Any other questions we want to ask him? What about family history? Is there something we want to ask about his family, or anything we want to ask in general? Family history of cirrhosis. So maybe not cirrhosis specifically, but yeah, we can ask about alcoholism. We can ask if there's any problems with the liver in general in the family. And when we're thinking about family history of cirrhosis, we might be thinking more along the lines of Wilson's disease, hemochromatosis, or alpha-1 antitrypsin deficiency. Those are more genetically caused. When we think about, substance abuse and stuff like that, maybe that's a little bit less genetic in that way. Mental illness, certainly. Yeah, that's a great question, Trish. That's a great question, because a lot of patients of whom are suffering from psychiatric illnesses end up, self-medicating themselves with drugs and or alcohol. So it's a great question to ask, because that's something we can treat, with medications, and they won't have to resort to that and inadvertently damage their liver as a result. So great job with that. I love that question. Is the drinking new or recent? Good job. Yeah, good job. You guys are asking great questions. I'm very proud of you guys. Okay, so what body areas do we want to examine on this guy? Yeah, the abdomen. Rachel said the quadrants. Which quadrant are we do we want to hone in on? We want to look at them all, obviously, if we're doing an abdominal exam, but what do we want to look at? Yeah, right upper. Exactly. Yeah, and we can look at the left upper too to look for signs of splenomegaly. We want to look at the right upper quadrant to look for signs of hepatomegaly, so enlarged spleen, enlarged liver. Good. Anything else? We want to look at the eyes. Stephanie said the eyes. Does anybody know, if you have jaundice, usually what are the first signs of jaundice? Where do you usually see jaundice first?
Yellow eyes.
Yeah, yellow eyes. Good. Exactly. You guys are exactly right. And sometimes it's a little more subtle. You usually see the conjunctiva a little bit yellow. It's called scleral icterus. And then sometimes, curiously, you can have your patient lift up their tongue, and sometimes you can see it under their tongue as well. So that's a little more subtle, if you think of it, but usually you can see it in your eyes first. And then by the time it kind of, progresses to having, full-blown jaundice where you can see them, that their bilirubin is usually pretty high at that point. All right, so here's our exam for this guy. So his temperature is 99.1. He's a little bit tachycardic. He's hypotensive. He has, a little bit low of a respiratory rate. He's at 11. So we might want to take that into consideration. He's lethargic and confused. His eyes, pretty normal, except for dry mucous membranes with scleral icterus. So that's exactly what I was just talking about, the yellowing in the eyes. He's tachycardic, but he has a regular rhythm. He has crackles in bilateral lower lobes, so maybe he has a little bit of fluid there. We don't know just yet. And he has a significantly protuberant abdomen with a positive fluid weight and positive shifting dullness. The liver is noticeably palpable with signs of hepatomegaly. So in the right upper corner of the slide, we see the patient's abdomen. What do we call this when we see this kind of fluid present in the abdomen? Good, yeah, exactly, you guys got it. It's a ascites. We see ascites here. And does anybody want to unmute themselves and tell me what a positive fluid wave is or positive shifting dullness? If you guys don't know what it is, it's okay. I'm going to explain it to you, but I want to see if anybody knows. And it's probably going to be easier to unmute yourself. So if you know it, go ahead. So we'll start with the positive fluid wave. The positive fluid wave, basically what you do is you get your hands on either side of the abdomen and you kind of slosh the fluid back and forth. And what happens is there's fluid in there that's kind of leveling out, and you can feel it go from side to side on your hands. So that's a positive fluid wave. And then positive shifting dullness test is what you do is you percuss the abdomen. So you take your fingers and you use them as a hammer, you percuss out, because fluid you know, has a different sound than air when you percuss. So you see where the fluid is when they're laying supine, and then you roll them to their side, and then you percuss out again, because the air is going to rise and the fluid's going to sink. So you're going to know that fluid is there. So that's what shifting dullness is. It's pretty specific for ascites fluid. Okay. The neuro exam was difficult to obtain secondary to the altered mental status, which, you know, we probably could have anticipated before. And then the patient also has jaundice, which we can see in this image on the bottom, and with scattered ecchymosis, which means bruises. And then the patient also has caput medusae on the abdomen, which, you know, we think that, you know, it is pretty specific to the liver, and we'll find why in a minute. All right, so I have a video here for you guys. So fairly short video. I'm going to play it again while I talk so you guys can kind of look at it in the background. But you guys know what this is showing? This might be kind of maybe part of his neuro exam, probably part of his neuro exam. So Stephanie said her dad had the exact same thing. Okay. Does anybody know what it's called or what it's a sign of maybe? It's obviously a tremor, but there's something very, very specific for it, what it's called. Think of the liver in this instance. So we know that the patient has hepatomegaly. There may be something going on with his liver. So this is called asterixis. And if you guys remember, if you were with me way back when we talked about GI bleeding, we talked about this increased ammonia in the blood. And basically what happens is when you put your hands out, it's kind of called a flapping tremor, like this. And you can kind of see his where he is able to like flap like this. And he has this tremor due to this increased buildup of ammonia in the blood system. And ammonia is able to cross the blood-brain barrier and inadvertently cause what we call hepatic encephalopathy. So this is the reason why he's altered, why he has this tremor. And it's because, you know, there may be a problem going on with his liver. So, all right, so let's talk a little bit about his labs. As we can see here, for his CMP, which is the one, let me get my pointer out here, which is the one over here to the left. So, and that's here. It looks like his sodium is normal. We want to kind of take a close look at that sodium. We want to make sure he's not hyponatremic, you know, due to this fluid overloaded state, and we would probably call that hypervolemic hyponatremia. Don't worry, you guys are going to learn a lot about this next week, hyponatremia, with Michaela next week. And hyponatremia is a tough topic, so I commend her for teaching that to you guys. She'll do a great job, I know she will. So, and then other than that, you know, our potassium was normal. Everything was really normal. Our chloride's normal, our CO2 is normal, our glucose is normal. So we're going to skip right over this one. Even his creatinine was normal, and his BUN was normal as well. So we're not too concerned about that at this point. We know his kidneys, you know, he is very acutely sick, but we know his kidneys are doing okay right now. And yes, Stephanie, you're absolutely right. The ammonia smell is very, very distinct. You're very right. It's like you can smell certain things in medicine. You could smell C. diff. I think GI bleeds you can. Ammonia you can smell. Certain things you can smell before you even see. Other than this, the liver enzymes, they are elevated. So AST and ALT, 2 different measures of liver enzymes. Those are both elevated. And as we can see here, the AST is greater than the ALT. Is that significant, or is that just, it just happened? Do you guys know? So AST is aspartate transferase, and then the ALT is alanine transferase, if I'm not mistaken. And do you guys know if does it mean anything that the AST is greater than the ALT? No idea. So yeah, aspartate aminotransferase, alanine aminotransferase, that's what they stand for. And you know, for this case, this does mean something. If AST, usually in alcoholic cirrhosis, we see this pattern. We see this exact pattern where AST is going to be greater than ALT. So this, you know, it's not significantly greater, but it is a pattern that we see in this regard. It looks like our coagulation studies are elevated. Is this significant or non-significant? Is this, you know, a coincidence, or is there a rationale behind why our coagulation factor or our coagulation studies are elevated? Yeah, good job. Good job, Parab. So for coagulation studies, coagulation factors are created in the liver with the exception of factor 8. Factor 8 is made in the endothelium of the vessels. And so really, due to this, if we have a problem with the liver, we have an intrinsic problem with the liver, then what we're going to see is a problem making coagulation factors. And so as a result, we're not going to be able to clot. If we're not able to clot, these tests that test the intrinsic pathway and the extrinsic pathway of the coagulation cascade, PT is for the intrinsic pathway, and then APTT is for the extrinsic pathway. Then what we're going to, I think I might have just said that backwards. APTT is for the intrinsic pathway, and then PT is for the extrinsic. I think I said it backwards the first time, but the last way I just said it's correct. So what we are going to see here is those 2 studies that test these coagulation factors and the ability to form a clot, they're going to be prolonged because we don't have clotting factors in order to form that clot. Okay. Ammonia is elevated, and then in addition to that, we see that the patient is anemic. We see that the patient has a hemoglobin of 9.1 and a hematocrit of 18.3. They're, needless to say, their platelets are okay, which is a good sign for us. And then their MCV is, what do we say? Is this elevated, normal, or low? For all of you that were with me for the anemia lecture, anemia is not going away. Yeah, it's elevated. Good job. So what do we call this? He's anemic with a large MCV. What do we call this? Good job. This is absolutely a macrocytic anemia. If you remember from that chart I showed you 100 times, I wish I would have put it on this slide for you guys. If we look at the macrocytic side of the sort of chart that I showed you guys, then liver disease absolutely produces a macrocytic anemia. This is all coming full circle. I hope you guys see that all these different things are really interconnected. So I wanted to make sure to make a little bit of plug there to anemia so you guys can see that. But all right, so we have our labs. There's a question down here for you guys. What additional testing do we need? What do we want to order? What do we want to see? Can we get more liver studies? Sure. What do you want? Yeah, GGT or yeah, alkaline phosphatase. Good. Yeah. So usually alkaline phosphatase is abbreviated ALP. We would want to see those. In liver disease, do we expect GGT and alkaline phosphatase to be normal, Elevated or decreased? What do you guys think? Take a guess out there. Elevated, increased, or those are the same. Elevated, decreased, or normal? Both will be up. Yep, you're right. Good job. What else? There's one thing that I want you guys to kind of pinpoint here, and it kind of is always last in people's mind. It's a protein synthesized by the liver. Good. Yeah, very good job. Good job for you guys that said albumin. Perfect job. And albumin kind of goes under the radar, but is so incredibly important for a lot of different things. It's a transport protein for a lot of different things, and really affects the fluid balance of the vessels, of the interstitial space, a lot of different things. So when our albumin drops, we lose that gradient and the fluid comes out, hence why we see this kind of ascites fluid in this man's belly. Good job, guys. Any imaging studies that we want to order? Do we want to order imaging at this point? What do you guys think? And what about the ascites fluid? What do we do about that? Ammonia. We had ammonia. Ammonia is down here at the bottom in the bottom left-hand corner. That was elevated. Anybody else? Retrograde cholangiogram, but I don't think it would be so useful here. Yeah, I don't think cholangiogram at this point would be indicated. One, because it can be a fairly invasive study and can be expensive, and a lot of times we want to jump to that unless it's an emergency, a true emergency. If we want to look at the gallbladder specifically, or we want to look at the liver, what might we start with first? Oh, Vivian already answered my question. Ultrasound. Yeah, we want to start with ultrasound. It's a lot of times for abdominal things, it's a good first test to start with. It's cheap, it's quick. We can get that going. GFR, yeah, we can look at GFR, but we know that and it's usually included in the CMP often. And his BUN and creatinine were normal. Anything else? Do you guys know what we're going to do about this ascites fluid? Are we going to just hope it goes away? Yes, we can drain his ascites fluid. What's that called? Paracentesis. Good. So we have a paracentesis in the stomach. If we want to drain it around the lungs, we call that a thoracentesis. Okay. So good job, guys. I think that we kind of got a good, wide span of tests here. So Vivian wanted to order the ultrasound. What do we say here? We're our own radiologists. We work in the smallest hospital in the world, and we have to do everything. So we're internal medicine doctors. We're also radiologists. So we also perform this. We're the ultrasound tech as well. So we perform this, we see this, and what do we say? So pull out your pointers, your annotation, use a stamp or a mark. What do you guys think? Is this normal or is this abnormal? We're looking at the liver, by the way. Does anyone want to venture to say it's normal? All right, you guys did well. Great job. So we are looking at an abnormal liver ultrasound here. And yeah, looking kind of bumpy. I was just going to ask you what makes you think that it is abnormal. And Emily, you're absolutely right too. The fact that it doesn't actually look like a liver is probably a good sign. His liver margins are irregular. That's perfect. Yeah, if you guys have seen a liver, if you've ever got to go to surgery, the liver usually is pretty, soft and shiny. Kind of has this little capsule on it, doesn't like to be messed with. And then, as we see insults to the liver, whether it's, poor diet, increased alcohol, it becomes friable. And so if anything kind of touches it, it likes to bleed. But what we should see, and what we're going to see in the next slide, oh, let me clear all this. Oops. Let's see. All right, and what we should see here on the left side here is what is normal. And sometimes the best way to know abnormal is to know normal. So what we see here is kind of the vasculature here, and we should see that fairly clearly. We should see, you're right, Emily, a smooth surface. We can see some vascularity here, which is perfectly normal. We see it branching here. And what we see is a smooth surface without kind of nodules. And then when we look to the left, it's absolutely different. We kind of see these nodules, and you can, imagine how this would look on a gross, specimen. We would see kind of, the liver sits in like this. And so we would see this kind of on a normal liver. And, when we look at this liver, it might kind of have these nodules on it. So you guys are absolutely right. You hit the nail on the head here. This is a cirrhotic nodule liver. It kind of has scarred down in kind of response to the chronic alcohol abuse. So good job with that. You guys are right on point with this. So we ventured to get a liver biopsy. And what do we say about this? Pull out your pointers and show me where the abnormal things are. Let me know where you see scarring, where you see abnormal things. Other than the liver biopsy, which is, abnormal, we also see on the peritoneal fluid, the fluid's consistent with ascites, which is, what we thought. Do you guys know what we were looking for in the ascites fluid specifically? There's a lot of things that we're looking for, but what are we trying to rule out? So on this liver here, we have a liver biopsy, and what we see is, yes, a lot of cells right here. That's not the primary part that I'm looking at here, though, because what we see is these hepatic, liver nodules here. We see one here. We see part of one here. And what these are these little things, and you can kind of see here, I just put a dot on one, you could see them all over. They're kind of side to side here. You could see the nuclei of the hepatocytes here. And what we can see in the middle here, and let me change my color, is we can see the scarring here. We see the scar tissue here, 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 here. We can see it kind of delineating these hepatocytes that are, being separated by this scarring. And yes, there is a lot of infiltration of cells here, so that is actually abnormal as well. But what we see here primarily is a lot of scarring in the liver, which is consistent with, cirrhosis, obviously. So can we tell if there are nodules if they are surrounded by scarring? Yes, because we know that these are hepatocytes. We know that the nodules are being surrounded by the scarring itself. So yes, we can absolutely tell based on this biopsy in general. So if you're curious, you can look at lots of biopsies. There's lots to look at on online. If you Google image search the liver biopsies, and you'll see a lot. You'll see kind of different extents of scarring. You'll see different staining. Sometimes it'll look a little more purple. And it all depends on the extent of the liver cirrhosis and whether it's macronodular or micronodular. And we'll go through that a little bit later when we talk about the classification. So in terms of the ascites fluid, what are we kind of ruling out here? When we stick a needle in the belly, we take out some of the fluid. We call it either diagnostic a paracentesis, which means we're going to diagnose the fluid, or we can call it therapeutic, meaning we're taking the fluid off therapeutically to help the patient. So in this case, it's, both diagnostic and therapeutic. He probably, given the size of his belly, he probably has a lot of fluid on it. So we take it off to help with shortness of breath. But you guys know what we're ruling out? It's something that has to do with infection. And what we call the infection with ascites fluid is spontaneous bacterial peritonitis. And we're looking for gram-negative organisms, if you guys have taken your microbiology class. And that is a very serious consequence of ascites. And that's what we're ruling out primarily with this, other than, looking at the other parameters, if there's cells, if there's blood, if the pH is high or low, whatever the case is. So we know that we have ascites fluid, we know that we have scarring, we know that we have a bumpy liver, okay? And then here, what we see, and it kind of gives you a, a little better cartoon of what we're looking at in the biopsies. On the left side, we see the normal architecture of the liver hepatocytes. So you kind of see this where, you see the central clearing, we see normal hepatocytes, we can see their nuclei. And then what we see in the fatty liver, and I primarily put this to show the fatty liver, is we see the deposition of adipocytes in the liver. So we see these white vacuoles. We see these white vacuoles in the biopsy, which is indicative of fat. And that is kind of usually the result of a poor diet, the standard Western American diet primarily. And then, down here we see a little bit of scarring. This one is, less easy to make out. I primarily didn't put it for, this biopsy, this, microscopic image itself, because you can't see a lot of the scarring itself, but I primarily put it for this fatty liver up here, so you guys get a good idea of what that looks like. All right, we're moving along. So before we click on, what's our differential diagnosis? What are we putting as number one? If we had to say this guy has this, what are we saying he has? Good. So I see a cirrhosis. Good. And good job, Vivian and Parab and Trish. I like that a couple of you have pinpointed the alcoholic cirrhosis, and that's important. We can't just say, if we're going to say somebody has anemia, we can't just say, okay, this person has anemia. We have to pinpoint what kind of anemia it is. In the same way, if we're going to work somebody up, we can't just put on our documentation, we can't just, tell the patient, we can't just tell other doctors that this person has cancer. We need to find out what type it is. So same thing goes for this. We can't just say they have cirrhosis. What type of cirrhosis? Because as we're going to find out here in a few seconds, there's a lot of things that cause cirrhosis, and we have to pinpoint the cause because, the treatment is inadvertently different, okay? So you guys are right. That's exactly what I have. I have alcoholic cirrhosis. So why do we think he has alcoholic cirrhosis? Yeah, his drinking pattern. Yeah, that wasn't a trick question. It was very straightforward. You guys got it. So likely due to his substance abuse history, his presence of ascites, and his presenting symptoms. He has a very and his tests obviously as well. What's our next differential diagnosis? What do we have next on the list? Think other causes of cirrhosis. What else do we want to consider? If he has a substance abuse history, did we ask him about illicit drug use, or did we ask him, if he has multiple sexual partners? I know he is married, but he could have had a history in the past of this. If he has hepatitis, yeah, exactly. It's exactly where I was going with that. He also has concurrent hepatic encephalopathy. Yeah, and then that's also here down on my list, hepatitis. The other thing that we want to consider is whether he has hepatocellular carcinoma. Having cirrhosis, whenever you get this scarring in your liver, you're more likely to progress to hepatocellular carcinoma. Yeah, good job, Ronald. You're exactly right. You probably beat me to it before I read your comment. And that's what I put as second. And you guys are going to learn when we list our differentials, we want to list them from most likely to least likely. And similarly, we want to put, the thing that could kill them first up at the top, and then those, more benign, less serious conditions at the bottom. Choriocarcinoma, less likely given the presenting symptoms. Usually choriocarcinoma presents a little bit differently. In late stages of choriocarcinoma, I suppose you can see cirrhosis as well, but this might have a little bit of a different presentation. We might see, scarring down of the common bile duct and stuff like that specifically, and see a different pattern, but maybe we can't rule it out so much based on the information that we have. So we could take it into consideration, perhaps less likely at this point. So hepatitis, do we want to order any tests for hepatitis, or we just say, well, maybe he has hepatitis, let's ask about his history. What tests do we order? How do we know if this guy has hepatitis? Yeah, hepatitis B surface antigen. Yeah, good job. You guys have taken some sort of immunology class maybe. But how do we differentiate whether this person has hepatitis or whether they've been vaccinated? That was for you guys who answered hepatitis B surface antigen. Viral load, yeah, if they have an active infection, we could see that. Yeah, we could look at IgG or IgG and IgM, being that IgM is acute and IgG is surface. We also want to look at those other parameters, which are hepatitis B core antigen, and we'll look at that hepatitis B surface antigen too. We can look at those antibodies as well. You guys are exactly right. Good job. Ronald, PPD is for tuberculosis. So along the line of infectious disease, but a different kind of course there. So we can't exclude hepatitis because we don't have the testing. So we'll want to order that too. And then on our differential 2, we want to consider Budd-Chiari syndrome. And really this is portal venous thrombosis. You're going to find there's 1,000 ways of naming everything, as I've kind of told you before. Budd-Chiari is a cute way of saying portal venous thrombosis, so blood clot in the portal vein. Okay. All right, so this is less likely given the patient presentation as well. He's not really, hypercoagulable. In fact, he might have a bleeding problem. His PT and PTT are prolonged. And then last here, I put that on our differential. I want you guys to think of it. We haven't really ruled it out just yet. We can get an echocardiogram to rule this out, to see what this patient's ejection fraction is. We don't know just yet. Their exam was normal when we listened, but that doesn't rule things out. So we could always work this up and see. Okay, or even get a BNP. That's BN, N as in Nancy, P, not BMP, a basic metabolic panel. BNP is a peptide released from the heart when it's damaged due to heart failure. So what do we want to do? We know that this patient has cirrhosis, but what do we do for this guy? Do we just say, well, not much we can do? You can go home. What do we tell this guy? What do we do to help this patient? Yeah, liver transplant. Yeah, good job, Parab. I would put that as my number one. The patient needs to stop drinking. And this is something that is near and dear to my heart. I've written something about this specifically, but substance abuse is a very sticky matter. And I included this in my writing, is telling a person of whom is an alcoholic who's addicted to alcohol, telling them to stop drinking is like telling them the sky is blue. at that point, it changes the neuronal connections in your brain. And now your body is really sort of focused on getting when you're going to get the substance next. So we're going to have to do a lot to help this patient. Can we offer them medications for this? Yeah, absolutely. Acutely, well, disulfiram, we won't want to give them that in the hospital. It won't really help them. Disulfiram is more of an aversion mechanism. It inhibits alcohol dehydrogenase, the enzyme. And so when you drink it, you're not able to metabolize the alcohol. So it causes a very, very severe reaction, and you get very sick. Curiously, if you ever give your patients Flagyl or metronidazole, it causes the very, very similar reaction. I actually saw a patient in clinic recently who took metronidazole and had a really bad headache. And the first question you should ask is, have you drank alcohol? Because you can have a disulfiram-like reaction with that too. So all of that to say, we might want to give them maybe a benzodiazepine, a short-acting benzodiazepine for their withdrawal. They may have a little bit of withdrawal. And then other things we can give them, or other drugs like naltrexone we can consider and stuff like that. We can help them kind of through their withdrawal so they don't have withdrawal seizures. And other than this, though, we do want to get them to stop drinking. And that goes along with Trisha's point. And that's, we would want, his liver is pretty severely damaged at this point. We have evidence of that, based on ultrasound, based on liver biopsy, which is the gold standard. And we know that he needs a liver transplant, but we won't be able to transplant this patient, give him a transplant, unless he's sober. So I think the rule is you have to be sober for like 6 months or 90 days, or I'm not sure of the exact timeline, but you have to be sober in order to even be on the list. You can't be getting sober while on the list. So this is more of an ethical dilemma that it goes into, but that's exactly what I put here. I put alcohol cessation. We want to do a large volume paracentesis. And then we also want to restrict sodium and fluids. We don't want him drinking a lot of fluids because he's going to become fluid overloaded, overload his heart, and we're going to run into new problems. The thing about sodium is when you take in sodium, water likes to follow. If you want to do an experiment, eat some like kettle chips tomorrow, or like some Lay's chips, and then watch your blood pressure rise. That's just because when you eat the salty things, the fluid's going to stay behind. You probably won't have to go pee for a while because the water is going to stay back and try to make a good tonicity in the blood. Okay. All right, so next thing, we want to talk to our GI friends. And why do we want to talk to our GI friends? What do we want them to be? What do we want them to see this patient for? Someone mentioned it in the beginning, I think. So this patient has cirrhosis, which can cause portal hypertension. And what can portal hypertension cause? Yeah, good job. Esophageal varices and varices of other mechanisms too. It can also cause rectal varices as well. So we want them to get involved for that. They might want to do an endoscopy or a colonoscopy to look for those things. And the thing about esophageal varices, and it's incredibly important, and I talked to you guys about this when I talked about GI bleeding, is that can cause a life-threatening hemorrhage. And so just the fact that he's had a little bit of hematemesis tells us there could be esophageal varices there, of which can rupture and kill this person, almost immediately. So we want to get this looked at, see if he's a candidate for banding, see if he is a candidate for beta blockers, which kind of decrease that systemic blood pressure and reduce the portal hypertension to minimize the risks. Okay. And then the long-term therapies that we talked about a little bit that we want to consider as a transplant. We also want to consider TIPS, and this is kind of an advanced procedure, which kind of involves, rerouting some of the vasculature. But that's above our level right now. So, and then the other thing we want to do for kind of symptomatic and also that increased ammonia, we want to consider rifamycin, an antibiotic, and lactulose for hepatic encephalopathy. The thing about lactulose is you're not going to make friends with the nurses for this one. What it does is, and in addition to that, you're going to want the patient to be fairly close to a bathroom or a commode, because when you give that to them, they're going to have to they're going to have to poop fairly frequently and often. So and that basically traps the ammonia in the colon and has them poop it out, so it's not systemic. It decreases that hepatic encephalopathy. All right, so now we're kind of to the pathology here. And when we talk about cirrhosis, it's scarring. It's scarring of the liver, and due to insults of the liver and insults to the normal architecture. It's often irreversible. That's why this disease is pretty grim. By the time we catch it, it's often too late. So this is also kind of a lesson in, if you see someone headed down that route, let's stop them there and try to stop them before it's irreversible. And I talked about this a little bit, but what we are historically speaking, these are the classifications. This isn't kind of live and die by these, because sometimes it's a little misleading. What we call macronodular is greater than 3 millimeters, and then micronodular is less than 3 millimeters. Sort of paradoxically, you would think that they start as micronodular and then grow to macronodular, but that's not true. So don't think of it that way. They don't grow to bigger ones. What happens actually is they start out as big nodules, and then as you get more scarring, as you can imagine, you have these big nodules with a little bit of scarring between the nodules, and then as you get more scarring, they kind of get smaller and smaller. So that's kind of the way that you can think about it. So really it goes like this, okay? That may come in handy whenever you take the quiz later. So again, this may come in handy when you take the quiz later. So there's that one. And other ways we can classify cirrhosis, and this is also above your level as well, but it's two different classifications. We use the Child-Pugh scoring system and the MELD. So Child-Pugh kind of gives you this, scoring that says, is it A, B, or C? A lot of surgeons use this to say, is this liver good? Is it not good? Can I operate? But this is Child-Pugh. It's based on kind of these lab values. MELD is kind of similar, but takes into consideration a lot of other things, has this, complicated formula up here, and there's calculators available for this. So, you don't have to sit down and calculate this and pull out your algebra from college. But that's kind of the classifications of cirrhosis, and there's a few different ways of going about it. It kind of depends on your institution, your preceptor, et cetera. All right. So here's kind of, why I was saying we need to pinpoint what caused the cirrhosis, okay? So what we were talking about tonight was alcoholic cirrhosis. Well, this was what our patient was. This was substance abuse, okay? So, and when we think of substance abuse, viral hepatitis, if we say that, the patient abuses IV drugs, IV drug abuse. So really, these kind of can go hand in hand, substance abuse, obviously here, wouldn't cause alcoholic cirrhosis, but hepatitis, viral hepatitis, can, because of multiple things. It can be due to IV drug abuse, it can be due to risky sexual behavior, multiple sexual partners, etc. Hemochromatosis or iron overload. You have a problem with this HFE gene, and then inadvertently are not able to, you get iron overloaded, and it likes to deposit in the liver, leading to cirrhosis. Here's non-alcoholic fatty liver disease. It's NAFLD. And this is the Western American diet. This is what I was talking about. And I see this a lot, and you're going to see it a lot. And the patient's going to go for, a CT scan because, you know, I don't know, they have a kidney stone or whatever the case is. And then the radiologist is not just going to look for the kidney stone, they're going to look at everything in the abdomen. And what they're going to tell you is there's hepatic steatosis of the liver, you know, consistent with non-alcoholic fatty liver disease. And then the patient's going to say, well, why do I have this? Do I have liver cancer? Do I have cirrhosis? And you're going to say no, but hepatic steatosis is fat in the liver. So as I showed you in that one, it's like those blank spaces in the liver biopsy. It's just fat depositing in the liver due to, you know, increased cholesterol in the blood and a poor diet. And non-alcoholic fatty liver disease is reversible. So that's one of those important things that we can kind of counsel patients about. And the thing about non-alcoholic fatty liver disease is if you expose your liver to multiple insults, it can progress into cirrhosis. So that's one of those things we can stop, which is important. The next one is autoimmune hepatitis. We have antibodies, specifically anti-smooth muscle antibody, of which attacks your liver. It's bad. And then the next one, Wilson's disease. That's what this picture is right here. They're called Kaiser-Fleischer rings. And I swear on every test, they always put the same picture. It always looks like some rendition of this. And you kind of have this brown ring around your eye. You know, don't get it confused with corneal arcus, which is lipid deposit around your eye. And what this is showing is it's copper depositing in Brusson's membrane of the eye. This is also a genetic disorder as well. Alpha-1 antitrypsin, we usually see this manifesting in the lung, causing shortness of breath and emphysema. But the problem with this is you get the liver globules kind of stuck in the liver because they're defective. We see these globules in the liver, which inadvertently leads to cirrhosis. So that's an important kind of, you know, black sheep to remember in cirrhosis. I like to test about that one. Then here's Budd-Chiari again, the veno-occlusive disease. We can see it in hypercoagulable states. You know, if a patient is has too much estrogen, if they have factor V laden disease, protein C deficiency, any of those things can lead to that. Okay. Then other things we want to consider, lupus. And what we look for lupus is lupus anticoagulant, and that's which can also cause, some of those antibodies can cause a false positive for syphilis also. And then the other one is medications. So we want to take into consideration medications. MTX is methotrexate, used for some autoimmune diseases like rheumatoid arthritis. And then isoniazid, that's used for tuberculosis. So there's where our PPD comes in. So that's the test we use to test for exposure to tuberculosis. Okay. All right, and then we see here on the bottom picture, we see this nodule bumpy liver. We saw that when we look at the ultrasound. Here's kind of the gross image of it, what we'd see on laparoscopy if we're doing a laparoscopic surgery. All right, we're moving right along here. So here's kind of a cartoon. We talked a little bit about hereditary hemochromatosis and Wilson's disease, but that's not really our forefront of today. But remember those Kaiser-Fleischer rings. That's going to be important for questions coming up. So remember that due to sort of a problem with copper transport, and it gets deposited in the eyes, in Brusson's membrane. All right, so for diagnosis and evaluation, what we want to consider is that jaundice. So they might be yellow, they might have gynecomastia, which means enlarged breast tissue, especially in men, and erythema. So you're going to see really red palms, and you're going to be like, what the heck is going on? And one of the most brilliant things I've always, I've heard a preceptor say is always look at the hands. You get so much about a person from their hands. And I know that sounds crazy. Well, why? But you know, you can see clubbing, you can see palmar erythema, you can see lots of things. And when you have a problem with the liver, you're not breaking down or metabolizing estrogen, so you get gynecomastia, you get a palmar erythema, which is due to the estrogen. You also get spider angiomata, which is kind of this little, I think it has like a cartoon up here, little dilations of the blood vessels due to the increased estrogen. Estrogen causes the dilation of blood vessels. You see that asterixis, of which we talked about before. We see this feeder hepaticus, which is like this very awful breath, which is due to the ammonia. We also see caput medusae, which is sort of this periumbilical vein dilation, also a result of varices. And then varices in the way of rectal and esophageal, which can cause GI bleeding. We see that encephalopathy, altered mental status, and ascites as well. So these are all a lot of things of which we talked about in our patient. Our patient showed up exactly like this. So very, very textbook presentation. And this cartoon, for you guys to refer back, has all of these signs, and I think is incredibly helpful. I used it for my studies for my board exams. All right, so labs, we talked a little bit about this already, but we'll see an increase in liver enzymes, AST and ALT, so aspartate aminotransferase and alanine aminotransferase. And as we kind of talked about, AST is usually greater than ALT in alcoholic cirrhosis. As Parab kind of mentioned, ALT or ALP and GGT may be increased, which are released from bile ducts. Bilirubin can be elevated, but keep in mind that bilirubin can be normal in compensated cirrhosis, meaning that the patient is pretty sick, but their body is compensated for this, so the bilirubin can be normal. So we can't see everything is kind of based off of that. We see a decreased albumin because it's synthesized by the liver. We see an increased PT, and then we could see decreased platelets, which is thrombocytopenia. We can see anemia, so just white blood cells. And then for autoimmune hepatitis, we could see an increase in ANA, which is non-specific. And then we can get a more specific test, which is that anti-smooth muscle antibody. Then in the way of imaging, we can do ultrasound, which is usually our first line test. We talked a little bit about that. As well as CT, we can do an MRI, and then biopsy is the gold standard for diagnosing liver cirrhosis. Okay? And then quickly in the way of complications, things we want to kind of consider here are portal hypertension as a result of, the liver kind of being scarred down. All those vessels being scarred down causes an increase in pressure in the portal vein. Ascites, spontaneous bacterial peritonitis, which is infection of that ascites fluid. Encephalopathy due to the increased ammonia in the system. You can see hepatorenal syndrome, where you have a problem with the kidneys as well. And the kidneys kind of get overburdened by the increased bilirubin, sort of get overwhelmed by all of these metabolites in the blood. We can also see bleeding as well, because if the liver is not making clotting factors, we're not able to form a clot. So that's why we're really kind of cognizant about preventing complications, because we don't want this patient to bleed out on this, because they can't clot. For hepatocellular, or for liver cirrhosis, we want to keep an eye out for hepatocellular carcinoma. We don't want that to happen. Of note, kind of one of the markers we look for is AFP in the blood to test for hepatocellular carcinoma. So that might kind of work up on this patient and make sure that they don't have a hepatocellular carcinoma already. But we didn't see a mass, so it's less likely. They have an increased risk of infection due to that leukopenia, that decreased white blood cell count that we talked about. And then as a result of all these complications, we always want to, avoid death, obviously. Okay, so I think I have some questions here for you guys. So like last time, these may be helpful for you in the future. Before we do that, let's talk about the treatment. So really the treatment here is to treat the underlying cause. The viral hepatitis, let's give them antivirals. For hemochromatosis, iron overload, we'll phlebotomize them, take some blood out, and then inadvertently take some iron. For Wilson's disease, use copper chelators like penicillamine. Alcoholic cirrhosis, we want to really emphasize drinking cessation, get them support, maybe those 12-step programs like Alcoholics Anonymous, which is immensely helpful. It's the most sort of well-vetted, helpful program for alcohol. Medication, stop the offending agent. Let's stop that medication and try to find an alternative. Veno-occlusive disease, if they're hypercoagulable, let's put them on anticoagulants. And then for autoimmune hepatitis, due to this autoimmune cause, we want to consider using, we want to kind of suppress the immune system using, steroids or azathioprine. All right, so I have a few questions for you guys to kind of practice your knowledge. Put these all the way at the end, you guys, so that you have all the information you need to answer these, hopefully. So let me put the question up for you guys. Let me launch it. So this is a 51-year-old female. She's presenting for an annual physical exam. Her exam shows hepatomegaly. Labs are positive for AMA, an anti-smooth muscle antibody. Patient is started on prednisone. So this should be very fresh in your brain, which is why I moved this to the very end. I was putting it before, kind of in the middle. So, and we're almost finishing up. So I'm sorry for going over a little bit. So I'll give you guys a few seconds. I want you all to be kind of answering and involved here. And if you guys have questions, feel free to ask those. I'm happy to answer any questions. All right, so it looks like most of you guys are in. I'm going to give you about a minute for each so we don't waste too much time. So let me share the results for you. 76% of you, a great deal of you said autoimmune hepatitis. Somebody who said autoimmune hepatitis, tell me why. How do we know this patient has autoimmune hepatitis? Yeah, good job. Anti-smooth muscle antibody, good. And the patient is positive for ANA, but we know that that's a little less specific. So what we can do, usually we test for ANA, and when it is positive, it tells us they may have an autoimmune process going on. So then we'll test for something specific. And in the presence of hepatomegaly, we may want to test for anti-smooth muscle antibody for autoimmune hepatitis. And the treatment is prednisone. So you guys are right on with this. Good job. You guys pinpointed this pretty well. Okay, so here's a new one for you guys. I'm going to relaunch the polling for you. So this is a 33-year-old female. She has a past medical history significant for factor V Latin. So she's hypercoagulable. She's presenting with bloating, jaundice, fatigue, and shortness of breath. Her CT of the abdomen and pelvis shows thrombosis in the portal vein. So what are we thinking here? I'll give you guys about a minute or so to answer this one. There's a few more out there. Twelve of you guys are sleeping out there. Or thinking really hard, I don't know. Either way. All right. Let me share these results with you. 56% of you said veno-occlusive disease, so Budd-Chiari, the cute way of saying they have a clot in their portal vein. So good job with this. So we know that the patient has factor V Leiden disorders. So we know that they're hypercoagulable. We know that having this a CT itself saying that there's a thrombosis in the portal vein, that's telling us exactly the pathology. So all we have to do is say the name, which is so good job with that one. It's pretty straightforward. Great job. So let me shine this and let me relaunch this for you. I hope you all get this one. I hope there's 100% for this. So this is 34-year-old male presenting with fatigue, jaundice, and impaired coordination. The exam shows this. So you look in the eye, you see this ring. What do you guys think? And then I think I have 2 more questions for you. And by the way, these questions, you may see these again. I like to, reward you guys for showing up and paying attention. So if you guys practice these questions and really apply your knowledge here, the quiz should be no problem for you. It should be very simple. Okay. I'll give you guys a couple more seconds. You guys are doing well. All right. Share this with you. So somebody who said Wilson's disease, please tell me why. What's going on? What do we see? The eye exam shows us something, but what are we seeing? And if you write it out, don't worry about the spelling. It's hard. Like the movie, like the scary movie. Kaiser ring. Yeah, good job. I think you may Googled that. I don't know if you spelled that out. If you did, I'm very, very impressed that you knew that spelling, because I had to make sure to look it up because it's hard to spell. And oh, okay, not the scary movie. Yeah, not the scary movie ring. But yes, we see a Kaiser ring. So that little brown ring around, and then it kind of different than what we talked about before. We see a little bit of impaired coordination here, which means that the copper's kind of depositing in the basal ganglia, the part of the brain for kind of defined coordinated movements. So we could see a bit of that as well. So good job with this one. Took a picture of the slide. Nice. Prepared this question. I think I have one more for you guys. Let me relaunch this for you. Let's shoot for 100%. We have a 44-year-old female presenting with an incidental liver finding on CT. The patient consumes fast food 3 times daily and denies alcohol use. So that kind of rules out one pathology over another. CT shows diffuse steatosis, so fat in the liver with prominent hepatomegaly, so big liver. You guys are doing great. Whoever put alcoholic cirrhosis, they don't drink alcohol. All right, the 2 people that put alcoholic cirrhosis, I think you're just messing with me. I even told you that they're drinking alcohol. So anyway, here you go. You guys did great. You got 92%. I'm ignoring the 2 people who put alcoholic cirrhosis because the patient doesn't drink alcohol. I know that you're being a little bit skeptical. I get it, but this one, definitely sets you up for non-alcoholic fatty liver disease. So the patient eats fast food 3 times a day, which I certainly wouldn't be able to tolerate. It sounds very heavy to me. And while the idea of eating fast food that many times maybe is exciting, I think the movie with the McDonald's kind of pops in my head, and now I don't want to do that. But yeah, this person definitely has non-alcoholic fatty liver disease. So due to the kind of an American diet, they get increased fat deposition in the liver. So good job with this one, guys. I think that is my last, but I have one final question for you. If you stick around for a couple seconds, let me relaunch this for you. I would just like to know, fill out this last question. I apologize again for going over a little bit. Sometimes I talk a little bit too much, but I want you guys to have all the information that you need in order to have a comprehensive presentation. I don't want to leave anything out for you. Can keto cause non-alcoholic fatty liver disease? I don't think so. I don't think I'm not entirely sure of that, to be completely honest, but I don't think the fat content's high enough for non-alcoholic fatty liver disease. But I bet you can find some, I bet you can find some research online about it. It causes more ketosis than anything, obviously. All right, so let me share this with you guys. Basically, you guys really kind of turned a corner here. Nobody said I know nothing. 2 people said I know a little, which I'll take. And most of you guys, 68% of you guys said I know some, which is great. I'll take that. And a lot of you guys have really come a long way, I think, with this, and I hope I've imparted some knowledge on you guys after this presentation. 5 of you guys said I know a lot, so I'm going to make you guys teach it next time. I'm going to find out who said I know a lot, and you guys are going to teach it next time. The whole C1, do 1, teach 1. You guys are up next. And the quiz is at the end of the SOAP note. 4 of the questions should be easy for you guys to answer if you were paying attention to this, and you should be able to get them right away. I kind of went through them, and in that way, only 6 questions you have to really think about. So great job tonight, guys. I'm really proud of your guys' progress over these sessions. Coming up, we have a few sessions. We have hyponatremia next. That should be a good one. It's a big prominent topic in internal medicine and in medicine in general. We are going to have one about CNS infections, which is going to be a good one, and then one about pneumonia. So we have a few good sessions coming up. Come back and see us. If you guys have any questions, please let us know. Thanks for coming, and have a good rest of your evening. Absolutely, Stephanie. You use that, use kind of the pain and the sort of experience from that to fuel your journey. And don't ever forget why you've gotten into medicine and all those things in medicine of which really have inspired you to do what you do and go through the challenges in your education. 30's like the new 30's the new 18. Agreed. It's true, it is. All right, if you guys have any questions, stick around. I'd be happy to answer any questions for you guys. You're very welcome, Zena. Your personal statement looks great, by the way. It's coming a long way. Anybody with questions out there?
Hi, yes, I do have one question. Do you see like an increase in like fungal infections or bacterial infections with people with psoriasis?
With psoriasis or cirrhosis?
Sorry, cirrhosis.
Okay, I was like, are we going to dermatology now? Yeah, good question. So what you really see is usually, any kind of infections really. If you look at, maybe one type of infection over the other, probably more bacterial in origin. And usually those might be kind of what we call hospital acquired infections. And it's usually due to the decrease in white blood cell count. And, you know, as a result, usually bacterial infections, that's not to say they can't get fungal infections also. Usually fungal infections, when I think of fungus, I think of diabetes. Usually they get a lot of fungal infections too, but you know, it's not completely unheard of. If someone's kind of immunosuppressed, if they have a decreased white blood cell count, especially if they're being treated with steroids, then you know, anybody's susceptible to increased infections. Does that answer your question?
Yes, and I do have a follow-up question about that. Just in the event of a fungal infection, because I do know antifungals are very hard on the liver and kidney, and so if they did have a fungal infection and they also had cirrhosis, how would you treat that if the antifungals would also be so hard on the liver?
Yeah, so you're absolutely right. The antifungals are cleared by the liver by those CYP450 enzymes. And really at this point, you know, there probably are selective ones that are less harsh on the liver, but, you know, if someone's battling an infection, sometimes what we say is, you know, the benefits outweigh the risks. You know, in the same way for pregnant women, sometimes of whom are suffering from seizures, you know, if they have a baby cooking in the oven, the risks of the baby and mom dying due to the seizure are higher than, you know, if we treated them with an anti-epileptic. So in the same in this regard, them dying of an infection might be a bigger risk than treating them and causing more damage, if that makes sense. So sometimes the risks do outweigh the benefits, and so or the risks do outweigh the benefits sometimes, and sometimes the benefits outweigh the risks. So you kind of have to balance that with the patient, and those are cleared by the liver. And we just have to take into consideration the big picture. I know that isn't a very specific, but really the answer is it depends. It depends on the patient itself.